Okay, Assalamualaikum warahmatullahi wabarakatuh dan selamat tengah hari. Beyond 12 already. So, I try to presentation saya akan jadi pendek, very short, very concise. Hopefully, you can gather something from what we're going to talk about this afternoon. So, I'm going to talk about POMR. Saya rasa kebanyakan peserta yang datang ke sini familiar dengan POMR sebab POMR telah diimplementasikan kepada major hospital di seluruh KKM. Okay. Sebab apa POMR dibuat? Pertamanya adalah to reduce cost and error to a clinical quality. Sebabnya, as a purchaser, which is the government perlukan access control to the cost and also access for the quality, which is overall net value is a value for the service that being given to the patient. And also, and second thing, they ensure access to the care. And that is why on the purchaser side, the importance of quality. Okay, as kita pembekal perkhidmatan, kita hendaklah demonstrate quality dan value kepada pembeli kita tadi, which is the government who provide kita fund. Dan juga kita safety, improve safety and also reduce medical error, and also to attract patient to maintain revenue. This is in general. Kalau in government sector, kalau kita attract more patients to come to the hospital, means that the more money we have to pay because it's being subsidized. But untuk private sector, the more patient goes into the hospital, seeks treatment there, means that more income, more revenue for the hospital. And what the patient gets is that high quality, affordable care. Bila diperlukan, and dia boleh maintain choice of doctor and so hospital. They're looking at government and private sector. Okay, QAP, Quality Assurance Program of Ministry of Health, dimulakan pada tahun 1985, in which they expanded into the variety of services: public health, pharmaceutical, dental service, engineering service, lab service, training, planning division, nursing, and also food safety and quality control, which is the latest, which is 2011. Ini yang Quality Assurance Program being initiated by the government. Sebab apa? Sebab yang pertama saya cakap tadi, because of as a purchaser, they nak control certain amount of things. Okay, MOH definitions of quality 2001. Facility and services are of high quality jika safe, effective, appropriate, efficient, patient-centered and consumer-friendly. That is bila semua satu sektor berjaya merangkumi semua 5 perkara yang disebutkan tadi, that is considered some form of quality is there. Okay, just to highlight regarding medical error, 44,000 ke 100, almost 100,000 American die each year from a preventable medical error. Maksudnya sesuatu yang boleh di-prevent. And medical error menyebabkan lebih banyak kematian berbanding MVA, breast cancer or even AIDS. This is a figure from United States. Okay. Surgical care, major cause of death and disability worldwide. This is a fact. So, keluar pada surgery sama ada post-operatively or post-ops. Maksudnya masuk ke mortuary. So it's either two-way, 50-50 chance. Okay. Some quality improvement activities that we initiated in MOH. Saya rasa kebanyakan daripada peserta who came from the MOH familiar with this term. NIA, National Indicator Approach. Pernah dengar kan? Pernah kan? Hospital Specific Approach, District Specific Approach, Confidential Inquiry into Maternal Death and Perinatal Mortality Review. Dulu sebelum sebut sebagai CEMD, disebut sebagai Maternal Mortality Review. Now they combine, maternal mesti ada anak, so they combine together. Okay, the topic of my interest, POMR, Perioperative Mortality Review, Quality Control, Infection Control, CPG, Incident Reporting, Corporate Culture, all the list below. And this is the initiative programs by the MOH in terms of quality. Okay, now I just scope down to POMR. Okay, what is POMR? Semuanya started pada tahun 1990, yang mana ianya berfungsi adalah untuk systematically access the quality of anesthetic and surgical services and the quality of the supporting services. So anesthetic, surgical plus supporting services with the ultimate aim in identifying shortfall and also offer remedial action or remedial measure to be taken. That is the aim of the PMR in 1990 when they are first started. Okay, the Perioperative Mortality Review Committee is a committee, a technical committee set up by the Quality Division to specifically look into the quality of the surgical and anesthetic service in the perioperative care in the whole government hospital in Malaysia. So, until now, the Perioperative Committee Review, ada orang masuk, ada orang keluar, keep on increasing the number. Yeah. Okay. The specific objective of this POMR committee, technical committee, is to, pertamanya adalah to collect data on the perioperative mortality in a selected government hospital in Malaysia when they are first started. Number 2, formulate strategy, offer recommendation to the Ministry of Health to reduce the perioperative mortality by identifying the remedial causes and any contributing factors that might lead to the perioperative death. The third is to produce reports at the appropriate interval. Number 4 is to provide advisory and consultative services. Number 5 adalah untuk provide professional expertise and also advice for educational program in relation to the surgical and anesthetic practice. Okay, this is something from the Annal of Royal College of Surgeons in England, auditing perioperative death. So I mentioned just now, one of the scope or aim of the committee is to for educational, training and evaluation. So Malaysia are at par with the European country in developing the POMR committee. It was all started by these two persons, Datuk Imba, which is the first, one of the senior consultant previously in the hospital called Mohd, and also Datuk Dr. Kandasamy. It's all started by these two persons. And they have the supporting members. Supporting members are the first who started the committee. Yeah, the whole list down there. And that is from the government side. So we have the private, sorry, the educational side. So we got support from the HUKM, Prof. Frida, Prof. Nafisa, and also Prof. Karis Misiran, which is a consultant. So they are the first technical committee who formed the Perioperative Mortality Review Committee. Okay, now we look at what is the perioperative death? A death yang berlaku within the length of the hospital stay, and that particular patient receive a surgical procedure done under by regional or general anesthesia, and it also included a death bila patient masuk OT tak sempat induce anesthesia lagi. Maksudnya patient is very bad from let's say from A&E, very bad MVA, datang masuk OT tak sempat induce, surgeon tak sempat cut, tak sempat apa, die. Any death occur in the operative theatre also being included as a perioperative death. Okay, and the death is considered a peri-anesthesia death regardless the time of the surgery, as long as it is occur within the same duration. Example, patient undergone complex surgery, let's say lobotomy, diverticular semua, is complex surgery, 3 months stay in hospital. Then after 3 months, baru the patient die. And it's still considered is a perioperative death. Let's say the patient after 2 weeks discharged back home, then datang balik readmitted, then it's not considered a perioperative death. As long as it is the same admission, it's considered a perioperative death. Okay, some other summary from POMR committee. It says that the inadequate pre-operative preparation, assessment, and lack of consultation being identified as a major contribution leads to the patient death perioperatively. Okay, we look some of the penyumbang kepada perioperative death. This is more toward anesthetic component. Pre-operatively, sebelum pembedahan, tak cukup assessment, tak cukup optimization, supervisor, lack of supervision. Lepas tu anesthetic terlalu mudah, weakness of the organizing system, dan keletihan. Intraoperatively, skill tak cukup, teknik tak betul, inadequate management, inadequate fluid management, and it's all there. Post-operatively, inadequate monitoring, failure to recognize complication, failure to provide a post-operative care to the patients. This is some of the contributing factor on the anesthetic component. But a surgeon, like Datin cakap tadi, a surgery is always a teamwork. It's combination of an anesthetic, a surgeon, paramedic, and a supporting staff. So bila semua komponen ni ada, then only the surgery will be performed. Okay, example, let's say a PPK tak ada, a PPK bantu kesihatan tak ada. So who is going to prepare the sucker? Who going to be changing the CO2 tank whatsoever? So semuanya play a role. So this is macam contributing factor for the surgical component. Inadequate assessment, inadequate optimization, almost the same. Lack of supervision, inadequate facilities, intraoperative, inappropriate procedure, lack of supervision, inadequate skill, inadequate facility. It's almost similar to what the contributing factor from the anesthetic part. Okay, isu yang dibangkitkan oleh komiti adalah emergency. Clearly stated by Datin just now, emergency and elective, two different separate entity. Emergency, you are lack in everything. You lack in optimization. You are not able to talk to the family member. A lot of things. There's a lot of issues regarding emergency. Intensive care facilities, specialist participation. Maksudnya specialist is part of the managing team, and departmental audit, which is M&M review. Okay. So when we look into this issue, and this POMR committee came keluarkan recommendation how to readdress perkara tersebut. So apa yang dicadangkan oleh POMR committee adalah reorganizing OT services to give priority to the emergency cases. Maksudnya emergency means ill patient, mostly ill, so they are giving priority to undergo surgery first. Okay, to develop protocol and guidelines in managing ill patient, ensuring appropriate stabilization of patient prior to surgery. Macam cakap tadi, on anesthetic component dengan surgical component, there is one element of tak cukup preparation, tak cukup stabilization of the patient before they undergo surgery as one of the contributing factor. Yang keempat, macam mana nak kata, menggalakkan atau memaksa dulu Kadang-kadang tu tak apalah, MO boleh buat kan. Sekarang is a specialist involvement, greater specialist involvement in managing ill patient. Adequate matching of surgical and anesthetic skill in carrying out operation. Example, you got a very complex surgery yang bagi gas baru 2 bulan MO NS. Yang buatnya is a very experienced surgeon. So dia tak match. Kan? So it's a complex surgery being managed a very junior, and surgeon yang buat is a very experienced yang tahu is a complex surgery. Or in the other way around, patient is a very ill patient on pacemaker, heart memang tak bagus, yang bagi gas is a consultant anesthetist. Very ill patient means that kita nak kurangkan period of anesthesia, because the longer period of anesthesia not good for the patient. And yang buatnya baru 2 minggu jadi surgical MO. Dia tak match. Maksudnya dia tak match the severity between both party. Yang kelima, increase the number of anesthetic in hospital. Menambahkan, sebab ratio tak kenal sekarang ni in terms of bilangan anesthetist dan bilangan surgeon di Malaysia. Properly equipped staff and trauma to manage the growing number of patients. Increasing number of HDW and ICU throughout Malaysia. Number 6, ensuring effective and appropriate utilization of the bed. Dah buat bed, tetapi bed tu mestilah properly be utilized. Not all patient, maksudnya patient yang betul-betul memerlukan care in the ICU or HDW. Dedicated emergency OT. Inward pre-op assessment of ill. Maksudnya, ill patient sebelum datang OT itself, pergi tengok dalam ward. Try to stabilize, or tak boleh stabilize in the ward, bringing to the ICU or HW. Try as much as possible to prepare the patient for surgery. And prioritizations of emergency case. Ada 20 list emergency. Siapa yang nak mati dulu, kita buat dulu. Try to prioritize. Kalau janganlah, kalau tidak, yang the first yang nak mati interact tu, kita buat last. Kita buat wounded right dulu. Itu maksudnya kita tak priority yang betul. Dedicated trauma OT. Complex surgery should only be done if an adequate critical care facilities are available, and there's a forming of a team to transfer ill patient from, let's say, hospital Yasin to hospital Melaka. This is recommendation. Maksudnya from district hospital to the tertiary center, there's a special training team, and conducting a regular M&M at hospital or hospital level. This is something from the University of New South Wales. M&M are an effective strategy to improve patient care, and part of the POMR is actually M&M. M&M being described as a unique opportunity for a caregiver to improve medical and surgical management through case study. Sebab M&M is go case by case. Kita tengok macam mana flow of treatment, flow of management, and how to rectify that. They provide clinician a routine forum for open examinations of adverse event, complication, and errors that might lead to the death of a patient. That is the role of the M&M. New Zealand Perioperative Mortality Review in New Zealand, it said that mortality review as a recognized key component in a healthcare system quality and safety.